ourselves, or?
Yeah, we'll take care of that. So everybody else will be muted, so that only you and me, and then we'll deal with the questions right at the end with one of my fellows. Okay.
Okay, sounds really good.
Okay. So
Okay.
good morning, everybody. Welcome to our weekly Cath conference. This week we're really lucky to have a very good friend, Roxane Mehran, who's going to join us and talk to us about a practical approach to antiplatelet therapy in the Cath lab. Rox, thank you so much for taking time out of your day.
Thank you, Dr. Latib, members of the faculty, fellows, all the wonderful friends at Montefiore Hospital. By the way, my dearest best friend is the professor there in nephrology, Dr. McCricky. I don't know if she's online. I did tell her that I was going to be giving Monty Cath conference today. So thank you for having me, and thank you all for listening. I was asked to talk about a practical approach to antiplatelet therapy. There's nothing practical about antiplatelet therapy regimens, unfortunately. I wish it was this case. I have many disclosures you should look at, especially given that I lead some of the trials that have to do with antiplatelet regimens in the Cath lab, and I also serve on the guidelines committee and the DAPT guidelines. So when you think about antiplatelet and what we're doing in the Cath lab, obviously each time we enter the coronary arteries, we are causing a little bit of chaos in the human body. And so the antithrombotics in general are the mainstay in allowing us to perform what we need to do without causing and disturbing the clotting system. And so during and after PCI, there are lots and lots of anticoagulants as well as antiplatelets that we are using. And we very, very much focusing this morning's lecture on the antiplatelet regimens, which is aspirin, dual antiplatelet therapies, P2Y12 inhibitors. I will talk a little bit about GP2B3A. Remember, that is an antiplatelet. It's the final common pathway of platelet aggregation, the 2B3A receptor, and the obviously inhibitors such as apixaban, eptifibatide, and tirofiban are there as an important inhibitor, and were being used early on until we became much more savvy with our antiplatelet regimen and the P2Y12 inhibition with the use of clopidogrel first, then prasugrel to cangrelor, and now an intravenous P2Y12 inhibitor, cangrelor. And I think it's important to kind of discuss that. If you go through the guidelines, I'm showing you the ESC myocardial revascularization guidelines because they're the most updated, 2018. And although our DAPT guidelines in 2016 are very much in line with this, in stable coronary disease, you're seeing the very, very first thing, whether it's stable, not unstable angina, or acute coronary syndrome with non-ST segment elevation MI or ST segment elevation MI, the very first thing you need to ascertain is whether or not a patient is at a high bleeding risk. It's a new way, a new dogma to think about that, because what we do both after the Cath lab and long after our PCI procedure, we have to be very, very much cognizant of the bleeding risk, because as soon as you have a bleeding risk, you start to have a shortened duration of DAPT. But in general, 6 months for stable coronary disease after stenting, 12 months in acute coronary syndromes, the same as STEMI, and then beyond 12 months or beyond 6 months, it's a consideration. It's not a strong recommendation to prolong dual antiplatelet therapies beyond. Now we have new strategies, which I will describe to you today. But before the treatment is the part that we have to, before you start your PCI, there is a question of, do we actually use dual antiplatelet therapy? Do we pre-treat patients? And how can we really figure this out? Well, the pre-treatment in stable disease is an interesting question. there is no true compelling evidence for a significant clinical benefit in patients with stable coronary disease. It's only an option in selected patients with high probability of PCI, and especially before your stage PCI procedures. This is a written document in the European Heart guidelines, as ESC guidelines, as well as based on a lot of work that was done in the previous trial, such that pretreatment in stable coronary disease and is not really very, very useful. But what about in unstable angina, non-ST elevation, acute coronary syndrome? Well, there have been studies done with prasugrel and ticagrelor. With prasugrel, the Cath trial did not show, and it really is not recommended if the coronary anatomy is unknown. With in Plato, we do know that early on, every patient at the moment they saw the patient, at the first medical contact, patients received the potent P2Y12 inhibitor with ticagrelor. So there is some evidence that there was association with benefit. Remember, in Triton, where prasugrel was approved, you received it only after you knew you were going to have PCI. And in a Cath, it really didn't show that pretreatment with prasugrel did anything to improve this. So pretreatment, it can be used. There's no head-to-head comparison between ticagrelor and prasugrel in terms of treatment. But remember, the ticagrelor in the Atlantic trial was also evaluated with pretreatment. And there, it really did not meet the statistical significance, but there was an important association with whether or not you give patients upfront, and I'll show you the data from Atlantic, where you give in those patients who received morphine, for example, there was a benefit with ticagrelor. What about STEMI? Well, the Prague 18 and Atlantic trial both looked at STEMI patients undergoing PCI. And there's no question, once you have the diagnosis, you probably should proceed and go ahead. This is the Prague 18 trial, STEMI, PCI. It was prasugrel versus ticagrelor, both of them. This is the head-to-head comparison. A very, very not obviously powered study with only 1,000 plus patients, but very, very important to see no benefit between prasugrel and ticagrelor or difference between them: death, reinfarction, urgent TVR, bleeding, or prolonged hospitalization. So very, very similar. So amongst patients with STEMI, either one of those drugs are probably okay. This Atlantic study that I told you I was going to talk to you about was administration of ticagrelor or in the ambulance or at the time of the Cath lab. And it was for STEMI patients in Atlantic. And you can see here that there was the ST resolution was no really different, whether you gave it in the ambulance for ticagrelor versus placebo, no real difference. And you're not really seeing an important benefit of upfront. But remember, in this trial in Atlantic, the average time was like 19 minutes between the STEMI being brought into the Cath lab and the procedure being performed was extremely short. So ticagrelor really didn't have a chance to get into the body. And there was an association in those patients who had morphine on board where there was really, really no benefit. So the pre-intervention treatment, really, we have all of these. And the truth is that whether or not which one of these are going to be the ones who could really, really help is very much dependent on their whether or not there's metabolism or prodrug related, whether or not the effective onset of when you think you're going to get the patient to start to work on their coronary arteries, and the duration. And cangrelor, this intravenous drug, which is an ATP analog, is reversible and does not need any prodrug. It's a really full, the drug becomes available immediately within 2 minutes, and the duration is about 30 to 60 minutes, seems to be a very interesting one, especially for our STEMI patient population. If we look at the effects of cangrelor in patients who are treated with other P2Y12 inhibitors, you really aren't going to have an important, don't worry, the receptors aren't going to be overflown, and it really is not an issue at all whether you give cangrelor on top of already given prasugrel, whether it was 30 or 60 milligrams, and you start to see obviously even a great benefit up front because you're seeing how quick cangrelor works, and the safety is there for these drugs. The platelet inhibition of comparing cangrelor with, let's say, crushed ticagrelor in STEMI populations is also interesting. You could give crushed ticagrelor as well, but you can see right here that how quickly cangrelor works, and especially on top of even crushed ticagrelor versus placebo, you could see it's really, really very, very effective and goes quickly. And it's important to think about the combination of these, but so that cangrelor actually can be given whether or not the patient has received prasugrel on ticagrelor. And if you're going directly into the cath lab and you really want to make sure that the effect is there and the patient didn't have the chance to get the ticagrelor or the prasugrel into a level, you really can think about a cangrelor infusion because it could give you quickly. Now, where's the data for this and how much benefit can we get? And here is where there's lots and lots of trials, but I think I'm seeing why there's not a lot of cangrelor use, because you see large numbers of patients who were treated in Champion platform, Champion PCI, where the cangrelor was given either to no clopidogrel and then given clopidogrel in the cath lab, or pre-treated with clopidogrel and going forward. And here in these two trials, there was no real benefit of cangrelor. But in Champion Phoenix, where there was the bolus and 600 or 300 milligrams, when a double-blind placebo control, you start to see the benefit. Here's the Champion PCI, and I showed you that the primary endpoint was no different in Champion PCI. Remember, Champion PCI, almost 9,000 patients, cangrelor bolus plus infusion versus clopidogrel 600 milligrams orally. No real benefit of cangrelor on the overall outcome of death, myocardial infarction, or ischemia-driven revascularization. It was not superior to the oral dose, especially if it was administered 30 minutes before the PCI. But in Champion Phoenix, when it was given versus clopidogrel, and we looked at the early, very early first 48 hours of major adverse cardiac events, and especially stent thrombosis within the first 48 hours, there was a benefit from cangrelor. And you see that here, and significantly reduce these important ischemic outcomes. And if you pool all of the Champion data and look at that early, the very early results from cangrelor. So if you have a very high risk PCI and you don't think your patient has gotten the potent P2Y12 on board, I believe that cangrelor could have a very, very important role. Well, what about the bleeding outcomes? We do know that P2Y12 inhibition, when you give the potent agents, you're going to have more bleeding. But remember also that for the early, for peri-procedural events, if we want to make a major reduction and we use a glycoprotein 2B3A inhibitor, which has been shown to help with these very early events, you're going to have a lot of bleeding. And we knew that bleeding was an important mitigation. But importantly, in Champion Phoenix studies and the Champion overall pooled analysis, when you look at cangrelor versus clopidogrel for severe life-threatening, if this is gusto, or moderate or moderate to severe, they didn't seem to have a difference. It was when you basically brought in all of the gusto bleeding. So there is some mild bleeding differential here. And if you bring all of it, you will have more bleeding with cangrelor. So it's not something you want to be using in everybody just because, and I think selective use in certain patient populations would be very, very important. And it is for this reason, I think, that the management of an acute MI patient presenting with a STEMI has a 2B recommendation here for cangrelor. And I believe they need to do a good STEMI study because I think this could be lifted to a higher recommendation if we actually show the important benefit of this, because it is, if there's one place where this is an important benefit, is in patients that need to get their artery open. Well, let me now go over the recommendations for guidelines. And the most recent one I chose was the 2018. We're right now working on the 2020 revascularization guidelines. But it's very important to read these and understand these, because I do think it does come very, very important. In the setting of a potent P2Y12 inhibition with ticagrelor or prasugrel, where the randomized data on GP2B3A use is limited, the routine use of these agents cannot be recommended. Nevertheless, it should be considered for bailout situations. And I think this is really, really important, especially for the cangrelor. What about after PCI? I told you we look at the high bleeding risk and then have this important evaluation between stable and unstable patients, whether it's non-STEMI or STEMI, 12 months. And then beyond the 12 months, it said to be considered risk-benefit ratio. And how did we get to this? Well, let me show you this slide. I love this slide from Marco Valgemigli from the European guidelines, which shows you how we came about. Every little dot here is, every little circle or whatever, a balloon or whatever you want to call it, is a clinical study on these different agents. Aspirin in white, ticlopidine in yellow. Believe it or not, that was an agent that was being used in the past, the very first P2Y12 inhibitor. Then we moved to clopidogrel in pink, prasugrel in green, and then ticagrelor in gray. The size of the circle is the number of patients and how many patients, but take a look at the number of studies from 1996 to 2017, a 20-year journey to help us evaluate and to get to where we are with dual antiplatelet therapies. And while we have these guidelines that tells us that maybe it's 6 months for stable coronary disease, of course, BMS is not even in there because we hardly ever use it, where you could get up to a month. You could go down to a month in a high bleeding risk patient in stable coronary disease. In unstable syndromes, there is 12 months and for high bleeding risk, you can reduce that to 6 months. And then beyond 12 months or 6 months, once you're done with the mandatory DAPT, you can make an important tailoring. And how do we tailor the dual antiplatelet therapies? And one of the things that has been a very important topic of the last decade has been in studying how we could reduce that mandatory DAPT duration. First of all, we have much better stent platforms. We have better imaging. We do better work in the Cath lab in our patients. And our procedures, even though they're becoming more and more complex, we have such good devices, and we've been able to use with the use of imaging that, and with our really, really thin alloys and cobalt chromium and biodegradable polymers, we've really gotten to a point where we could reduce the duration of DAPT that's mandatory and can't be stopped because patients have to live. They have other things to do. And so there is this lots and lots of studies that have worked hard to really look at a shorter duration of DAPT, and plenty of these studies, a lot of them have, some of them have imaging like IBIS XPL. There is multitudes of looking at 3 or 6 months versus 12 months of DAPT. And basically what they have shown here is that a shorter duration of DAPT is non-inferior to the 12-month DAPT for the composite of ischemic net clinical benefit. This is really for stable coronary syndromes, and that's how we have the 6-month duration. But what about prolonging DAPT? Patients, this whole hypothesis of not just stent-related complications, but outside of the stent. What about reducing myocardial infarction and late stent thrombosis, and reducing type 2 MIs? Well, many studies have also focused on this. And these were 6 versus 24 or 18 months, 12 versus 24, 18 or 30 or 36 months. And really the most important one, the largest of all, is the DAPT study, which was close to 10,000 patients, 12 versus 30 months. And let me tell you what it tells you. It tells you that you could prolong DAPT and reduce myocardial infarction and stent thrombosis, but there is an inconsistency in mortality. The mortality was in the wrong direction in the DAPT study. There could be an increase overall mortality. So it really leaves us with an inconsistent evidence of higher efficacy for longer duration of DAPT. But there are certain patients who could really enjoy the benefit of that, of prolonging DAPT. And what this is telling us is that not one size fits all. I think the best possible study that could really look at this is this master DAPT trial. I like this study because it is using it seems very complicated, but they're selecting the patients, they have a pretreatment, and this mandatory DAPT in 4,300 patients using a singular stent platform, UltraMaster, is looking at a 1-month DAPT, and the trial population have to be high bleeding risk, free from myocardial infarction, no active bleeding at the time of the 1-month duration, and then going to a after 1 month. And once they meet those criteria, they get prolonged DAPT versus abbreviated DAPT with the really important understanding of net adverse clinical events, major adverse ischemic and bleeding events. So this is a very important study. It's finished its enrollment, and we're looking for a very important result from Dr. Valgimigli and colleagues who are leading this trial. But where we are today is in the era of these risk scores. And I'm a culprit of also producing one of these risk scores, but there's 27 of them. And if you are a clinician, you get lost. Which one do I use? Which one could be better? Well, we developed the Paris score. Bobby Ye and Laura Murray and team developed the DAPT score. And the precise DAPT investigators, Marco Valgimigli and Franco Costa, they did the precise DAPT score. So these 3 scores are the ones that are probably a very interesting tool for you to use. Let me tell you a little bit about the Paris risk score. Comes out of a registry. So it's all comers. Everyone is included. It's not a pick and choose how many months you were on, if you're high bleeding or not. Everybody got in, and each patient has a risk score for bleeding and a risk score for coronary thrombosis. So this is how we were able to evaluate that, because within the patients in the Paris registry, we were able to use the collective evidence in coming up with a bleeding score and a thrombosis score, and actually showed some overlap of the scores, showing that some patients who are at a higher bleeding risk with some bleeding risk parameters are also in the ischemic risk parameters. So it really does make you want to kind of think about a tailored approach to these patients, and understanding that if you just have major bleeding, you're not cured of your ischemic events, and you still have to think about, in some of those patients, where you weigh the balance and try to give them the best possible result. So does everybody need a short DAPT? And the answer is not. I mean, you can take a look at the and graph the bleeding risk versus the and put in, and you can see in the low bleeding risk patients, there's a large number of these patients who are also low thrombotic risk, but there is a good number that have intermediate and high risk, 30% plus 30%, 35% or so. It's the intermediate risk patients who really have a lot of thrombotic risk. And it really comes to that high bleeding risk patient where you start to have an important understanding of where you fall with your thrombotic and bleeding risk, a lot of overlap. So very important to think about these two parameters of intermediate and high bleeding risk, where we could really shorten the duration of DAPT. The DAPT score is another one that is actually very, very easily used. There's a wonderful calculator. It's very simple to use. And basically, you come up with parameters that gives you a score for a net clinical benefit of both bleeding and ischemic. So these are the predictors of ischemic events. These are the predictors of bleeding events. They put it all together. They excluded predictors that were overlapping. So it's interesting. But what's important is that if you have a DAPT score less than 2, which is a low score, then you really should not be getting a prolonged dual antiplatelet therapy, because the bleeding risks are high and you're not really gaining any kind of a benefit in benefiting the patient. So you could see right here that in the high DAPT score, the net clinical benefit is huge. You just need to treat 34 patients, and I think that's really, really important. It's also important to understand what's going on with the bleeding risk. Thrombotic risk is very, very early on, but also is the bleeding risk. But it's something that continues onward, and it is persistent across the board. But it is highest in that very first month, the same time where the ischemic benefit is the ischemic events are the highest. So this is a very, very difficult dilemma for all of us to figure out. The precise DAPT score is another score. This one is actually really simple. You look at whether the patient had a prior bleeding, is the white blood cell count up, what's the age of the patient, the creatinine clearance, and then the baseline hemoglobin. You can get up to 100 points. And what they showed very, very nicely is that the majority of the patients, if you pass the precise DAPT and you don't get above 25, a large group of these patients can enjoy the benefit of and remember, these are mostly, especially ACS patients, a long, prolonged DAPT. And one of the things that they did do, which I really like very, very much, is apply the DAPT score to the complexity of the procedure, because it's not just about demographic, it's also about the anatomy of the patient. So if you have a complex procedure, you start to move more in the direction of a prolonged DAPT being better for that patient. And especially if your precise DAPT score, your bleeding score is less than 25, you start to get a really, really good benefit for these patients, where you see the benefit of ischemic benefit outweighing the bleeding benefit. So again, very, very important to think about the risk-benefit ratio on how you can put this into the context of a high bleeding risk patient. So if you don't have a high bleeding risk, the benefit of a prolonged DAPT trade-off is better if you go with a prolonged DAPT. If you have high bleeding risk, you don't derive any benefit with prolonging DAPT unless you have a complex procedure. And when both features are present, bleeding more than ischemic risk should inform your decision making. So once you go above the 25, you really have to be moving in that direction of shortening the duration of DAPT. I want to make sure you understand why there are problems even with these risk scores, because the way the risk stratification approach works is we take the clinical trial and we divide it up, and this is from John Spertus, by the way, and I think he does a beautiful job explaining this, that we take the whole clinical trial patients and we put them into these buckets: the low risk outcome, the intermediate risk outcome, and the high risk outcome. And that's what they are. That's what the patients are. The patient comes into the trial, they're either low risk or intermediate risk or high risk. Then we put them into the clinical trial, in a randomized clinical trial, and what we come up with is this mean treatment effect. For a patient, an average event that comes out of these three different types of patients who were put into the clinical trial. So what risk scores do, they provide answers for average patients. But in real life, there are no average patients. So the tailoring of the DAPT duration and the use of these risk scores are extremely dynamic. And we cannot say, well, I use the risk score so I know I'm safe because of exactly what I just explained to you. They're useful to improve the accuracy of your prognostic acumen of how you evaluate the patient, but they can't be considered your clear-cut decision-making tool. They're just there to guide you and kind of give you a checkbox that, yes, you're in the right direction. You are, you made the right choice. You did see something. And there are some things that are not in the risk score, like frailty and what you're seeing the patient as, that makes you make those important decisions. So finding this sweet spot where you gain the most benefit of the lowest ischemic events and the lowest bleeding events is something that's extremely very, very difficult in daily practice. And that's what we try to do. For every patient, we want to do no harm. We want to protect them against ischemic events because we just did a PCI. We don't want that stent to thrombose. We don't want them to have a myocardial infarction. In fact, that's the reason why we're now performing PCI. And we don't want to give, so therefore we give them P2Y12 inhibition, maybe potent ones, but we also don't want to increase the risk of bleeding. And so what this takes is this big balancing act that's extremely difficult. And how do we prioritize? Well, the prioritization is very, very much related to the high bleeding risk, a little bit different between the US and the Europeans. I think the Europeans are a little bit ahead of us as usual, like they are with the coronavirus, but we are moving in the direction of kind of becoming very, very close to each other in making important evaluations. How did these guidelines come about? Here's the prasugrel data versus clopidogrel, showing a very, very big benefit of using this in patients with an acute coronary syndrome. Potent agents are superior to clopidogrel in reducing ischemic events, stent thrombosis, but there is a bleeding price that you pay. But remember that the bleeding events are there and we need to make sure about them. But it is no question that mortality did not differ. There was increase in major bleeding, but there was a huge reduction in ischemic events in this irreversible P2Y12 inhibitor. The Plato study looked at a more of a inclusive patient population, first medical contact, ACS STEMI, clopidogrel treated or naive, randomizing them to clopidogrel versus ticagrelor, 6 to 12 months exposure, a reduction in the major adverse clinical events of death, MI, and stroke. The bleeding events, they say no difference, but there is a higher non-CABG related bleeds. there's no question there is an increase in the non-cabbage related bleeds. What about ticagrelor versus prasugrel now? There is these two agents absolutely superior to clopidogrel. Which one should we choose? The ISAR React 5 was the study in acute coronary syndromes that included STEMI and non-STEMI patients. This group of investigators in Germany did a beautiful job, presented this list just last year, comparing ticagrelor to prasugrel. But what's important for you to understand how different it was for each, how they used the treatment randomization, not equally between the two arms, very, very different. For prasugrel, remember that in prasugrel patients, in non-STEMI, you needed to have the angiogram. So there was no pre-treatment. Then they received prasugrel after the angiogram and PCI was performed. And here in STEMI, they were similar. The duration of therapy was up to 12 months, and they looked at it in combination with aspirin at 75 to 150 milligrams. They were looking for showing a superiority of ticagrelor over prasugrel for no clear reason at all. I just showed you Prague that doesn't show any difference between them, but they felt that there could be an important benefit. And here they actually showed the opposite, where ticagrelor was inferior or prasugrel was superior to ticagrelor. In terms of the primary endpoint of death, MI, and stroke, with no difference in bleeding endpoints, which made everyone imagine, how could this be? First of all, both drugs are working in the same way. And if you are reducing bleeding complications with a potent, ischemic complications with a potent agents, you should at the very least have some bleeding price to pay. And in fact, it shows that ticagrelor had a higher bleeding. So it really just didn't make sense. But it's a study. Everyone is talking about it. Prasugrel is cheaper. It is not associated with all the shortness of breath that ticagrelor has. But I can tell you that about 35% of the patients did not receive the assigned treatment that they were given. And so this funny outcome of prasugrel superiority over ticagrelor will need to be tested again. But certainly it tells you that it's important that both of these drugs, at the very least, can be used concomitantly in the same way in ACS patients. What about the long-term use? The Pegasus investigators in TIMI 54 trial looked at two different dosing of ticagrelor versus placebo with a background of aspirin. Long-term use showing a benefit of ticagrelor over placebo. For longer term, in patients with prior MI, 21,000 patients, but they showed a high level of bleeding. And so the bleeding was basically very similar to the ischemic benefit. And therefore, that is the reason why the longer treatment with ticagrelor is a 2B recommendation in our guidelines and in the European guidelines. What about the ticagrelor in patients with diabetes? The THEMIS trial was just presented this past year. Large numbers of patients, and remember, here they were looking at diabetic patients with CAD without a history of MI or stroke. Do they drive a benefit from aspirin and ticagrelor in a prolonged fashion? And here they did show that over an ensuing period of up to 54 months, that there is a benefit that begins to happen about a year or 2 years after treating patients on long-term aspirin ticagrelor, and that there could be a benefit. And they do have a very interesting and good label now. And the benefit was definitely at an expense of increasing major bleeding. So once again, you have to balance bleeding versus ischemic benefits. But if you have a young diabetic patient, I would be thinking about using these kinds of issues. Now, all of this was really bothering me because there was a lot of this overlapping risk, a lot of issues about what to do, how, long, short. And each time we talked about going from a dual antiplatelet therapy to a single antiplatelet therapy, the idea was that we should drop the P2Y12 inhibitor and continue aspirin. And so I wanted this question answered, and so did other investigators, about this alternative approach. Can we safely withdraw aspirin when you have a novel potent P2Y12 inhibitor that's on board, or even any P2Y12 inhibitor on board? Who says that we should have aspirin forever and ever? Well, the global leaders investigators did this in the largest possible trial, 16,000 patients. They wanted to actually show a superiority of a ticagrelor monotherapy over the reference strategy. So the experimental strategy was all of the patients received aspirin and ticagrelor only for 1 month, went to ticagrelor monotherapy, versus the reference strategy that showed what we do in our guidelines. The problem here was that in stable disease, they were still giving a 1-year treatment of clopidogrel. And they wanted to show superiority over this whole reference strategy. And unfortunately, they just missed it. The p-value was 0.07, so they did not show benefit of the experimental strategy. But to me, this was a positive trial because they didn't show a signal of harm. We were always scared to stop aspirin because it's such a great drug for secondary prevention. But when you have ticagrelor on board, do you really need aspirin? And I think, or when you have a P2Y12 inhibitor on board that's potent, do you need aspirin? Well, other investigators said, well, what if you have clopidogrel on board, especially these days with our best possible stent strategies, like with the Zion stent? So the STOP DAPT2 investigators looked at a 1-month duration of DAPT, but here, instead of dropping the P2Y12 therapy, they dropped the aspirin and continued with clopidogrel monotherapy, compared with the reference arm of 12 months of DAPT in these patients. And here they showed a very, very important no difference between in death or myocardial infarction, and a major reduction in bleeding. So their net adverse events was in favor of this new strategy of P2Y12 monotherapy. The Smart Choice investigators in Korea did a very similar thing, this time with different stent platform, randomizing a 3-month DAPT versus a 12-month DAPT. And here, these patients elicited on monotherapy of P2Y12 inhibitor no harm compared to dual antiplatelet therapies in terms of major adverse clinical events, and a reduction in their bleeding events, just as we had seen before, compared to 12 months of DAPT. So a very, very important, 2 important trials with clopidogrel monotherapy. Now, I would say these are Asian patients, much more prone to bleeding complications, less prone to the ischemic complications. And so maybe clopidogrel works here, but I'd be very scared, especially knowing that 30% or so of the patients could be going home on or leaving after a month on placebo if they are not responding to clopidogrel. So I would be cautiously optimistic about a clopidogrel monotherapy. We performed, however, a prospective randomized trial, the Twilight study, where we actually included patients who had both bleeding and ischemic risk profile, complex patients, in whom the doctor wanted to send the patient home on aspirin and ticagrelor. So we got a lot of ACS patients, 65%, but we had 35% of our patients who were non-ACS and stable coronary disease, but they had complexity of their lesions and their profile as far as being diabetic, CKD, etc. Everyone got treated with 3 months of open label aspirin and ticagrelor at 3 months if they were compliant with their medication. If they did not have adverse events, ischemic and bleeding events, they were then randomized to add ticagrelor plus aspirin versus ticagrelor plus a matching placebo. This is the only double-blind prospective randomized study in ticagrelor monotherapy versus ticagrelor plus aspirin. What we showed in this blinded study is a significant reduction with numbers needed to treat of only 30 patients to get a reduction in bleeding events when you drop aspirin. So ticagrelor could do its work if aspirin is not around, because it will allow it to be there for a longer period of time, because you won't stop it because there's bleeding complications. I mean, bleeding rates really reduced, and there was no signal of harm whatsoever. And so I think what we showed here is substantially less bleeding without any increase in ischemic harm. So in summary, and it's a long way to get there, I think for the Cath lab, the P2Y12 inhibitor in the Cath lab, you want to be able to give these patients, for ACS patients, definitely the potent agents, ticagrelor or prasugrel, if the patient can tolerate it. You must know that prasugrel cannot be given to patients with prior stroke, age greater than 75, and low body weight. Ticagrelor, on the other hand, can be given to these patients. They don't have any restriction. The important restriction of ticagrelor is with a low dose aspirin, always low dose aspirin. And maybe now we have a possibility to go to ticagrelor monotherapy. We're learning more and more about these important P2Y12 monotherapy in reducing bleeding risk without increasing ischemic, without decreasing ischemic protection. But I think what's really important is to think about how important is bleeding as well as ischemic complications. They both come into account, and we have to make important choices, hence going forth. Cangrelor, finally, can be considered in patients who are not pre-treated with an oral P2Y12 inhibitor, especially if they can't absorb the oral agents and there's a STEMI going on and you really need your platelet inhibition on board rather quickly. So I want to thank you for your attention. It was a whirlwind tour, but I want to thank you for this, and I'll take any questions that you may have. Thank you.
Thanks, Roxane. That was fabulous, really. It was a very complete overview, and I think, I don't think it could be any shorter than that. You really had to cover.
I'm sorry, yes. So we still have, I think, 10 minutes for this, right?
Absolutely, we do. Right? So I'm going to let Shun, who's one of our interventional fellows, ask the questions and moderate the discussion. Shun, you can just unmute yourself and you can go ahead.
Great. Thank you, Dr. Mehran.
Thank you. Hi, nice to meet you.
Nice meeting you too.
You're very lucky you work with Azim Latif.
Definitely. That was an amazing overview, and I really appreciate it's such a complex topic. I think, you're the expert in this field. And I think the problem that I've been having is that it's such a common question with so many options to try to treat these patients. And there's such a heterogeneous population with bleeding risk, ischemic risk. We want a simple answer, but there's no simple answer.
No.
One thing that I found interesting when I was at Sinai Beth Israel, I think the Sinai system uses like a reporting system that outputs DAPT score automatically. Like when you finish the report, I thought that was kind of useful, especially when you're done with the PCI, you kind of know that, okay, they are either high bleeding risk or not. I know it's not the one solution of it. There's more complexity to the patient. Do you find that to be useful? Do you incorporate that into practice?
Yeah, so really good. The DAPT score was put into into our Cath lab system immediately after it was published, because it really gave the physicians an understanding of not it's not really a bleeding score. It really is a net benefit score. So if you have a high, if your DAPT score is above 2, you really have to worry about ischemic complications in that patient. And I think that's how you have to kind of think about it. What it's not a really good bleeding score, and so therefore, I think it makes it's not the best possible. Remember, it came from the DAPT trial, so the patients had to have had a whole year of dual antiplatelet therapy regimen on board, do well, have no ischemic. I mean, these are a very selected group of patients. So at the time of PCI, it's not actually the best score to use. It's a great score to have in your clinic, where you see these patients coming back and you're thinking about stopping, and the patient is saying, I don't want to be taking, I'm bruising everywhere, I don't want to be taking this blood thinner anymore. The DAPT score there could really help you and your patient in a shared decision making. Say, look, I understand the bruising is bad, but you know what? You are at a very high risk. If we stop this now, you are at a higher risk. Yeah, you'll bleed more, but you're also at a higher risk for ischemic complications. So I think that's a good way to put the DAPT score. The precise DAPT score is much better for bleeding, as is the Paris score, because we included patients on oral anticoagulants. We have all kinds of things, and it's at the time of PCI. So I would say that you could use those, but those, again, the risk scores are just there to give you a guidance. They're not really there to make your brain is no substitute. This is no substitute for your brain, is what I'm saying. Your brain is the one. The doctors still reign supreme, where they still have to make those important decisions in their patients. Although I think the machine learning and electronic health records are learning a lot about what we're doing and how it's affecting our patients, and it will change over time. But up to now, for now, you still get to make the decision.
Sounds good.
We don't have much time. I don't want to keep Dr. Mehran more than past 8:30. So maybe choose some of the best questions from the chat. There were quite a few that you want to address to her.
Yeah. So it's a very interesting question that I'm very curious as well. So there are reports of stent thrombosis associated with COVID, this COVID outbreak, pandemic, and we definitely saw a couple of cases of that. Have you changed any of your DAPT practice, preference of any P2Y12 inhibitor over the other, duration, any changes with the pandemic?
Yeah, I mean, I think with the pandemic, I think the COVID patients in general are at a higher risk for especially coagulopathies. And so they might be on other agents. So it may be that, what you don't want to do is expose them to a higher risk of bleeding. So it all depends on the patient. Once again, the more complex the patient, the more you have to kind of figure out the risk-benefit ratio. I haven't changed any of my practices. I look at the patient as a whole, and I think I try to use those selectively. Importantly, I think and I see some of the questions about the P2Y12 monotherapy. I think that really is something for us to think about. The guidelines are just thinking about how this is going to come about. There was a meta-analysis that was just published where it showed where you go to a P2Y12 monotherapy, you will reduce bleeding without increasing ischemic harm. There are some issues about stroke. Even in Twilight, we saw 0.5 versus 0.3 stroke, so a 0.2% differential. So, maybe if someone's at a high risk for stroke, you might think about it, keeping them on aspirin a little bit longer. But I think if you want to keep the protection against, especially in your acute coronary syndrome patients, I believe stopping the aspirin earlier so that they can enjoy the benefit of a potent agent for a longer period of time without having a bleeding could be very beneficial in these patients overall. So I took one of the other questions quickly.
Thank you. kind of interesting question. In case of high thrombus burden in ACS,
Yeah.
have you experienced any use of intracoronary bolus of cangrelor?
I don't feel that you need to do that. Cangrelor works systemically when you give it intravenously. We have not given it in the, within 2 minutes you have an effect. The reason why people are doing this practice is because with the glycoprotein 2B3A inhibitors, there was definitely some data that showed infusion of 2B3A inhibitors can reduce thrombus burden, reduce thrombus size. I was part of one of those trials that Dr. Stone was running. But I think in general, intravenous cangrelor should be the way to go, and making sure you have a good intravenous line. And I think that's important. We've seen often, for example, with bivalirudin, where we've seen thrombosis and it hasn't, the IV line isn't there. And unfortunately, if you really should check your ACT to make sure, and once you know that your ACT is good, then you must have a good IV line because you gave heparin through that same line, and then the cangrelor should be working well too.
Sounds good. One more question. As an academic person and a clinician, how do you convince your colleagues or your patients that why prasugrel in the ICER-REACT-5 trial, why prasugrel may not be the preferred P2Y12 when that's the clearly shown benefit in that RCT?
I know it's really hard. I think Azim needs to bring me back to give you my dissection of the ICER-REACT-5, and I just did it for one of these webinars. It's online somewhere where I think it was TCT Asia Pacific, or no, ESC. It's for ESC. I'm doing this for ESC, where I show what the issues are. First of all, a lot of the patients did not get the assigned therapy. That's a flaw. Many of them, many patients, especially if they were in the ticagrelor arm, did not get ticagrelor, and they were switched over. And they weren't even discharged home on ticagrelor. These centers were mostly in Germany. There were 2 centers in Italy. Most of the centers were in Germany. So it really is not representative of the global aspect of this. And the number and the differential in how these drugs were given in a randomized study, in an open label randomized study, where that once you get ticagrelor, physicians are always, oh, you're going to get shortness of breath. Oh, let's stop this. You have a shortness of breath. And so there's a lot of bias. And that was the reason why we felt that you needed to do a blinded study if you were going to withdraw aspirin, because aspirin is widely available and the doctors could get, oh, go take aspirin if you're like, don't worry about the study drug, et cetera, on the patient by the same token. So what we didn't have that. The patients didn't know if they were getting aspirin or not in Twilight. So there is a lot of issues and dissection of that clinical trial. But nonetheless, I don't know. It could be true. We have to do a really good study and design one and go forward with it. Hopefully we can do that.
Absolutely.
Sounds good. Dr. Lateeb?
I think we have very quickly maybe Theo's question, and if we have time for Mike's question, because I think they're both very relevant.
Sounds good. So if you could maybe discuss about assessing platelet reactivity prior to making decision on DAPT, considering shorter duration.
Yeah, so a really good question. We didn't cover AFib patients, so that's a whole nother. Literally, that's a whole nother grand rounds. Honestly, it's so much. I just couldn't. It was such a broad topic. I think you have to have 1, 2, 3, 4. It's a 4-part study, but the use of platelet reactivity in engaging and guiding your therapy has never worked so far with clinical studies. So there's no clinical trial to say you should be doing this, because it just doesn't. It hasn't shown. But I hate to blame it on the platelet reactivity testing and that guidance, as opposed to the trial designs that looked for a huge benefit, tried to get small numbers of patients. You need large numbers of patients, and I promise you, it probably does work, because we do know that, you know, if your platelet reactivity is not there, if you have a high platelet reactivity on clopidogrel, you're going to be very, 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 very hard pressed to stop aspirin and send that patient home, especially if you just did a left main stent and the patient is an elderly person that you don't want to keep on prasugrel or on ticagrelor. So, you know, there has to be some guidance there, but in everybody, I absolutely don't think is needed. If you look at Taylor PCI, where they use the CYP2C19 gene allele presence and guided their therapy, there was benefit in that first 3 months. You know, it was they didn't show benefit at 1 year, but the meat of the trial was in the first 3 months. So I think they also missed their endpoint. And so I think, you know, so much of this rests on how we do clinical trials. That's why I think clinical research is so important, is that, you know, we should really try to answer the question definitively. We shouldn't try to fit the trial to the question, but rather make sure that the trial answers the question by having it to be large numbers and well designed. So do I use it? Yes, in selective cases, I think platelet reactivity is really, really important.
Rox, last question really, and a practical question from one of our fellows, or previous fellows really. In patients who are on DAPT who need surgery, generally, you know, you stop the P2Y12 inhibitor because most surgeons will still feel comfortable operating on aspirin. Now, in the twilight scenario where the patient's only taking ticagrelor and now needs surgery 4 months after their PCI, what do you do?
Yeah, so very, very important. And we had a whole plan set up for these patients where we didn't unblind the patients at all. And we will be reporting those. So I don't want to show, those are one of the very, very important sub-studies of Twilight that we will be presenting, the patients requiring surgery and what we're doing. This whole field of what to do around the time of surgery and bridging and not bridging, or which one of these things is really, really an important one, and an unmet need that needs a large clinical study to evaluate. And we're hoping to be able to design something that could answer those questions. But that's a really, really good question. You'll know about it at TCT.
Okay, so Mike, you're gonna have to wait a little longer. Rox, thanks so much for taking an hour out of your day. This was fantastic. We really appreciate it. Okay, thank you.
Thank you.
Stay well.
Bye.
Love you. Bye-bye.
Bye. Love. Bye.